Now I request our next speaker on current outbreaks of adenovirus, mycoplasma, influenza and COVID, Dr. Syam Kukreja. Sir, please come as a speaker. And our panelists, Dr. Joydeep Chaudhary and Dr. Aparna Chakravarti. Panelists, Dr. Joydeep Chaudhary and Dr. Aparna Chakravarti. And chairperson, Dr. Hans Vass. Sir.
कौन सा खोल दे इसको हेलो हेलो मैं किसी और को बुला रहा हूँ साथ में बुला रहा हूँ मैं उनको बुला रहा हूँ डॉक्टर धीरेन आप आ जाओ डॉक्टर चिटकारा जल्दी तो नहीं है जाने की ओके So I'll be talking about recent outbreaks, and my panelists are Dr. Jaideep, Dr. Aparna, and Dr. Dhiren. Dr. Jaideep is a ID expert from Kolkata. Dr. Aparna is ID expert from Amrita Hospital, and Dhiren you know. I think Dhiren took the last lecture. Okay. Now, we'll be talking about these three diseases, mycoplasma, adenovirus, and influenza. They were in news in several parts post-COVID. And these were in news, for example, Chennai reported a lot of mycoplasma. We also had a mini outbreak. Then we had scarlet fever. Again, in Delhi, we had a mini outbreak. Adenovirus, yes, we had good number of cases. In fact, I interacted several times with Dr. Dhiren on this subject when there was cases. And Delhi recently, we had a webinar with BLK. There were cases of adenovirus infection, influenza B infection in our cases recently also. So these were the three outbreaks we suffered, and I'll be talking about those. Basically, my cases are simple. I'll be talking about approach, like you have a patient in your OPD practice or you have a patient in the hospital. How will you approach such patients? So I'll discuss all these issues later on. Now this is a child, case 1, because the time is, now 20 minutes? Okay. अरे यार कोलकाता से बुलाया उनको 20 मिनट के लिए. Okay. Age is 3 years. 6 months, fever is 9 days, 103, onset with runny nose with cough, similar illness in the family. The child is breathing fast for last 2-3 days, tachypnea with mild respiratory distress, chest there's a bilateral wheeze, and there are crepitations more on the right side. And this child is receiving amoxiclav for 6 days. And in fact, this child was being treated by me earlier for nephrotic syndrome and came to me after, say, 3 or 4 weeks after having stopped steroids, after having taken an adequate course, daily 6 weeks and then alternate day 6 weeks. Okay, this was the X-ray. This was the presentation and this is the X-ray. Okay, now blood culture sent. I will ask brief questions and answers. भेजेंगे sir blood culture? Yes. So blood culture will be sent. The reason is, in a garden variety of pneumonia, there's hardly anything. You won't get, because they're mucosal pneumonias, there won't be any blood culture positivity. But in a case which is admitted and sick, blood culture sometimes can be very, very useful. It will bail you out. Okay. What's the provisional diagnosis in this case? Aparna, what is your feeling? What it could be?
So this 3-year-old kid comes with a very respiratory syndrome. So when we diagnose infectious disease, we usually do it in syndromic diagnosis. So most of the features here are respiratory tract. So it involves the lower respiratory tract as well. This kid has a similar illness, history of similar illness in the family, and that kind of gives a clue that it could be a viral infection which has been in the household. Did receive antibiotic, but there's no response, as we could see that the child came with respiratory distress. So again, that's another clue that this is more of a viral. Here, the twist is the child has been on steroid for nephrotic and just been off steroid for just 1 week. So still falls in that immuno...
Compromised state.
Yes. So here, of course, this with the history, this is more of a viral illness. We need to keep in mind that this child is also in that immunocompromised, and we think about secondary infections, though antibiotic has been given here.
Okay, I agree with you. This could be viral. This could be viral with secondary infections. Any other thoughts? Any other thoughts? Be rapid. कोई भी बोल दो. Dr. B.B. Agarwal is also come. Please come, sir.
Atypical organisms, number one, we have to keep in mind. And number two, fever is 9 to 10 days.
Yes.
And
that's
it's quite
very
high fever. There is a past history of nephrotic syndrome on steroids also. So, whatever you told, whenever a child is admitted, definitely it merits a blood culture. X-ray is somewhat suggestive. CRP is high. Of course, I will start an antibiotic and we'll do an upper respiratory PCR also.
Okay.
Because if there are some organisms which might not be commensal, because see, some of the organisms are usually not commensals. So that will alert me.
So it could be viral.
Sir, yeah,
Yes.
I agree with everyone. You are given 4 choices. I'll say if this case would have come a month back, influenza with secondary infection number 1. Secondary, because you told us that you're going to talk about 3 infections. Then sometimes adeno. If you look at the X-ray, go back to the X-ray. One point I want to make out, which normally we tend to miss. If you look at the intercostal spaces, lung is bulging. This is the one indication of hyperinflation other than your diaphragm or flattening. So that is one point also favoring the viral.
Nice.
And of course secondary infection because it is almost 8th day, 9th day. So my first diagnosis influenza and second can be adeno because you already cleared up that you're going to talk about 3.
So it has to be out of the 3.
Yeah, third one is the mycoplasma. I won't say because in mycoplasma cough is very uncontrollable cough. Tracheobronchitis is present in almost 100% of patients. So third diagnosis can be mycoplasma, but my 2 will be 1 and 2.
Okay.
It is also 3.5 year. Mycoplasma normally.
So what treatment will you give to this patient upfront? अभी investigate करते हैं, but patient has come after blood culture. What treatment I should give upfront? Dr. Agarwal.
We like to start the antibiotic ceftriaxone and plus azithromycin because the mycoplasma is still not ruled out, and might consider adding antiviral oseltamivir.
Is there a role of oseltamivir after 48 hours?
No, it is no role.
But this patient
But
is having
duration
sickness for 9 days.
That is the reason we have said the last. We might think of, but it is not required.
आप देते हो practice में जी, Dr. Aparna?
No. So antiviral oseltamivir will work best within the first 48 hours. So after that, it's kind of not really working.
We normally avoid it, but in a very sick patient,
depends on the severity of the illness.
sick patient
Yes,
and with CNS
immunocompromised.
infection, we do give it. If we are
Immunocompromised as
Okay,
well.
okay.
So if I can say,
Anyway, we started with the same Dr. Agarwal suggested.
Sir, anti-staph I would like to add because staph is also secondary infection very common with this one.
Chalo,
Especially
okay.
if your patient is so sick, CRP is high, though means then I can withdraw later on, but presently I would like.
You could have given Vanco as well. Okay.
so if anti-staph, I mean, we
See,
actually...
such opacities in MRS इतना शरीफ नहीं होता यार. नहीं, MRS से इतना शरीफ नहीं होता. Vanco देना चाहते हो. देखो जरा X-ray को देखो. It's more like reticular interstitial opacities, isn't it?
Exactly. So if I have to say...
Markings are prominent, more in favor of a viral rather than the.
Okay, anyway, I was coming to this only. What are the key differences clinically? कि भाई ये viral होगा, ये mycoplasma, ये bacterial में fit होगा. What are the clinical differentiation? Anyway, because there's a shortage of time, I'll summarize this by this chart. In bacterial, it is sudden and severe. If, for example, it's a pneumococcal, it will come within 2 days to you. The child will become suddenly sick. There's a high fever. Cough is minimal. Why the cough is minimal? Because it is a parenchymal involvement. The bug will sit in the parenchyma, and parenchyma doesn't have cough receptors. So there may be mild cough. The blood-tinged sputum may be there on the day 1. And chest pain will be there because they have pleuritic pain. So these children are sick. Now go to viral. The onset is very gradual if it has to develop pneumonia. It won't come on day 1. 3 to 5 days following URI symptoms. Fever is usually mild to begin with. Cough is plus. Runny nose is there and sore throat may be there. Now go to mycoplasma. It takes a little longer, 5 to 14 days. Fever is mild. Cough plus, persistent dry hacking cough. And as Dr. Dhiren was telling you, fatigue, headache, myalgia, rash, arthritis, means multi-system involvement may be there in case of mycoplasma. So this is in summary. This is not hard and fast. Any bug can break the rules also, but usually this happens.
Adeno is an exception. It may present in a very severe way.
Severe, very severe, but again it takes some time.
Yeah, it takes some time.
Takes-
Not at.
We
as
have
fast.
seen adeno after coming 5-6 days.
And then is the mycoplasma, we can associate extrapulmonary
Yes,
manifestation.
that's what you said, multi-system
that's
involvement. Again, there's another confusion. There are a lot of papers where they say the mycoplasma can be a mixed infection also.